All right, let's talk about the Gold 2024 report on COPD. So, number one, here's the definition of COPD. You need to know that what we were taught in medical school was that there were two most common phenotypes, those two being chronic bronchitis and emphysema. But it's important to note that these classic distinctions have actually never been included in the Gold Report definitions. However, for the sake of pathophys, let's use this delineation for just a second. So, chronic bronchitis, it's a chronic productive cough lasting at least 3 months over a minimum of 2 years, highly associated with smoking. And why does it happen, right? So, you have mucinous glands in the submucosa that produce mucus in order to filter out particulate matter. People who smoke introduce a whole lot of particulate matter in their lungs, and these mucinous glands increase in number and size. They ramp up their production of mucus, and guess what? They empty it into the lumen and they cough it up. And now you have chronic bronchitis. Some of that mucus goes back and plugs the airways, and now you have air trapping and obstruction. And that's why you'll have the increased PaCO2 and decreased PaO2. And what about emphysema, the other side of the coin? So emphysema involves destruction of alveolar air sacs. But how does that happen, right? So again, people who smoke, they introduce a whole lot of inflammation. And inflammation acts like proteases, and it also increases the activity of proteases, which will kind of degrade and deteriorate your alveoli, the actual alveoli sacs. So you get a loss of elastic recoil, collapse of your small airways. So you have these initially tiny balloons and they turn into big bags, and the big bags can't participate in gas exchange, and they really can't expand like they should. So number one, you have that protease, right? The proteases that degraded. But on the other side of the coin, you have anti-proteases, which should help you to not have that effect. But people with alpha 1 antitrypsin deficiency can't protect against inflammation, because what is alpha 1 antitrypsin, right? It's an anti-protease. So you either have increased inflammation with increased protease activity, or you have not enough anti-protease or alpha 1 antitrypsin deficiency. So both of those can lead to what we know as emphysema and COPD as a whole. Okay, so what's the presentation, right? This is a very classic presentation. Again, I'm not one to reading slides, so I'll let you read that. But these people they're out of breath, they're breathless, and it's a very distressing symptom. And these people, it's like the worst thing ever. And what did I not include on this slide? Wheezing, constant tiredness, weight loss, muscle loss, anorexia, um, pursed lip breathing. We know all of these things from medical school, but when you see it firsthand, it's very distressing, and these are some of the sickest patients. Okay, so diagnostic criteria. A ratio FEV1 over FVC less than 0.7 post bronchodilation. I'm not going to go over spirometry. I think that's an entire different video on its own. But that's the diagnostic criteria, right? Okay. And we also have something called PRISM. So some people can have respiratory symptoms or structural lung lesions without airflow obstruction. So they have a normal ratio, but their spirometry is just abnormal. And they're at risk of developing airflow obstruction over time, but not all of them do. And these people are called pre-COPD. Okay. Another thing important to note is that you should not screen for COPD. It's actually not recommended, but you should have a low threshold for using spirometry as a diagnostic test if you suspect COPD. Okay. So that's an important distinction to make. And here are two questionnaires. One is the CAT and one is the MMRC. And this is just how the patient feels that their lung condition is affecting their life. And why that's important is on the next slide. So you can use the CAT score and the MMRC for grading A, B, and E. And okay, we know in the past that for medical school, maybe if you were in medical school at the time I was, it was the old ABCD algorithm. It was in practice for years, with the high exacerbation risk categories being C and D. Starting in 2023 and carrying into this year, which is 2024 at the time I'm making this video, C and D are no longer used. And this kind of streamlines the algorithm for patients who are naive to therapy with groups A and B. and then E, which encompasses the old C and D. So if that's confusing what I just said, it's in the diagram. It's pretty clear. And the severity of the airflow limitation is defined by the predicted post FEV1. So that's how you get your grades. So the grade is based on FEV1, okay? But A, B, and E are actually based on the history of exacerbations, okay? What is a severe exacerbation? A severe exacerbation means they required either an ER visit or a hospital admission. A moderate exacerbation means they needed systemic steroids or antibiotics, but not an ER or hospital admission. And this is important, okay? Another thing that's important, treatment decisions are not based on spirometry or the stage of obstruction, but they're based on symptoms, risk, and history of exacerbations, okay? Again, I'll repeat that. Treatment decisions are based on symptoms, risk, and history of exacerbations. Okay. And here's the basic treatment protocol. Okay. Your goal is to reduce symptoms and reduce the future risk of exacerbations. There are two types of inhalers for COPD, the bronchodilators, the LAMAs and LABAs, or the anti-inflammatories, the ICS. Now, groups A and B present people with very few exacerbations, one or less moderate, and no COPD-related hospitalizations. People with group B have a little bit of a higher symptom burden, and the American Thoracic Society actually recommends starting with a dual bronchodilator therapy for initial therapy because it gives them better bronchodilation with no significant increase in risk as compared to a single bronchodilator. Now, group E is where people fit in who have had more significant exacerbations. Specifically, I guess the definition, if you want to go into that, is 2 or more moderate exacerbations requiring systemic steroids or antibiotics or a hospitalization or ER visit for COPD exacerbation. Okay, so for those patients, you want to start with dual bronchodilator therapy. However, there's a nuance here. If the blood eosinophils are over 300, then you would consider starting with triple therapy, LABA/LAMA, and ICS. So the treatment is kind of stepwise, right? If you choose to start with a single bronchodilator and they're still symptomatic, you'll want to bump it up to a dual therapy. If they're still symptomatic, you have a couple options, right? So number one, if they're having exacerbations on a single bronchodilator, you'll want to bump it up to a dual therapy, okay? But if their eosinophils are greater than 300 or they're already on dual therapy, then you'll want to escalate to triple therapy, okay? Now, if patients on triple therapy still have exacerbations, then you'll want to consider adding roflumilast or a macrolide like azithromycin. And you should consider withdrawing an ICS if they have pneumonia or any other symptoms like that. Okay. So, in summary, don't hesitate to use dual bronchodilator therapy, and don't hesitate to escalate to triple therapy if patients have, a more significant exacerbation burden. And again, remember that treatment protocol is based on symptoms, not on the spirometry results. Okay. And these are factors to consider when initiating ICS treatment. You should probably not use them if your patient is having repeated pneumonia events or they have eosinophils under 100 or a history of infection, of course. All right. And what are the recommendations, right? Stop smoking, number one. You'll want to get your vaccinations as well, influenza, COVID, what else? Pneumococcus, tetanus, pertussis, even shingles if they're over 50. Exercise, pulmonary rehab. These are all great things and great recommendations. Oxygen therapy as well for those with severe resting hypoxemia, less than 88%. I think it's been shown greater than 15 hours per day increases survival. So these are all the recommendations. I tried to make this very succinct and general overview, and I'm still somehow almost at 10 minutes here. But yeah, this is the GOLD report for 2024.